Many of you watching today will have supported the Royal Free Charity through giving your time, money or advocacy, and I want to take the opportunity to thank you all. It's because of your support that we and the Royal Free London can go beyond the limitations of NHS funding to achieve our joint clinical and research ambitions. Welcome back to those of you who've joined us in previous talks, but for the benefit of those joining us for the first time, I'll quickly run through tonight's format. In a moment, I'll introduce and hand over to our guest speaker, Professor Sir Chris Ham. If you've joined us on Zoom, you can type questions in the Q&A box throughout Chris's talk, and we'll do our best to get through as many of your questions as possible in the panel discussion, when we'll also be joined by the Royal Free Medical Director, Dr. John Connolly. We're recording this event and we'll be posting it on the RFC Presents YouTube channel, where you can also find recordings of all of the earlier events in this series. If you enjoy our discussion this evening, I do encourage you to share the recording with others. But now to the talk itself. I'm delighted to introduce Professor Sir Chris Ham, one of the country's leading experts in health policy. A former chief executive of the King's Fund and an advisor to governments at home and abroad, Chris is also a non-executive director at the Royal Free London. And it's from this perspective that he talks to us this evening with a particular emphasis on population health and working in partnership to tackle inequalities. So Chris, over to you.
Thank you very much, John. I hope you can hear me okay. I'm getting a sign on my screen saying I might be muted, but is this okay?
Yep, we can hear you.
Yep, great, thank you. Well, I'm delighted to be invited to give the talk this evening, and I'd like to thank various colleagues at the Royal Free who've worked with me on the development of our work on population health. Too many to mention by name. You know who you are, and I wouldn't be able to do this evening's talk without the incredible support I've had from a number of public health colleagues. So thank you sincerely for that. I wanted to divide what I have to say into two parts. First of all, providing some national context about COVID and the lessons from it, and then moving on to talk about what we've been doing at the Royal Free London Hospitals Foundation Trust. And in doing so, I will draw on the work from the King's Fund that I was involved in when I was chief exec there until the end of 2018. Let me say to begin with that I've written previously at some length on the lessons about governance and leadership from COVID and the failures of policy learning by the government there have been over the last 16, 17 months or so. These failures resulted, as we now know, in many avoidable deaths because the decision-making around the response was over-centralised. Not enough was done to draw on the expertise of local government, the NHS and others, and mistakes were made, and unforgivably, they were repeated with tragic consequences. Now, of course, the vaccination programme has been a huge success, but for most of 2020, the government got it wrong in the delays when lockdowns were introduced, the way in which the policy on test, trace and isolate was slow to develop and to grow, the reluctance to impose border controls and much else besides. So I'm not going to say a lot more about governance and leadership, but I do want to say that up front because I think there are some really important lessons we've all learned. So I'm going to take those failures as a given. So let me move on to the talk itself. If I can have my next slide, please, on celebrating the 70 years of the NHS, which in fact is the next slide beyond that one. That's it. Thank you. I wanted to go back to begin with to 3 years ago, almost exactly to the day when we were celebrating the 70th anniversary of the NHS and its many impressive achievements. Particularly, I would highlight the improvements we've benefited from in health, including substantial reductions in premature deaths across the population from heart disease, from strokes, and from most forms of cancer. And of course, much more beside. As has often been said, the NHS is as close as we have to a national religion, and we are all grateful to know it's there for us at times of need. The 70th anniversary, an occasion to recognise and to celebrate that. If I can move to my next slide. Shortly afterwards, the beginning of 2019, we saw this document published by NHS England, setting out a long-term plan for how the additional spending for the NHS allocated by the government was going to be used, an ambitious plan to further improve health and care, setting out a large number of priorities, particularly with a focus on the prevention of ill health, the focus on care in people's homes and in the community, the use of digital technologies where they could bring benefits, perhaps above all, care that was more joined up, care that's more integrated around people and around communities. Much more besides, but those would be some of the headlines set out in the long-term plan in January 2019. And I want to come back to that later because I think those priorities remain important. On my next slide, of course, then totally unexpected, along came COVID, which changed everything. And the focus had to shifted towards critical care in our hospitals, including in the Royal Free, shifted to how we could discharge patients from hospital who didn't need to be there to free up beds for the critically ill patients who did, shifted to online consultations wherever possible, both in hospitals and in general practices, to make it possible for our patients to access advice and care and support without having to be there in person. And of course, one of the big lessons here from COVID is the way in which our clinical teams were at the forefront of the response. Most of the hard work was done by those clinical teams within the national framework set out by the government and then elaborated by NHS England. And we owe them a huge debt of gratitude for what they've done over the last year and a half and the way in which they've been agile, responsive, have been able to put in place the best possible services that we need to reduce the harm and the avoidable deaths from COVID. Part of that was the emphasis that we saw, a stronger emphasis, a welcome emphasis on mutual aid between general practices and between hospitals supporting each other when they were under extreme pressure. And of course, linked to that, the emphasis on partnership working, not just within the NHS, but with local government and with the voluntary and community sector organisations who played a critical part. So in 2020, the long-term plan, but then the challenges of COVID. If I can move to my next slide, we learned many lessons, and one of them was it quickly became clear that the pandemic was affecting some groups in the population far more than others. This is Michael Marmot's report. I sat on the committee that worked with Michael back in 2010 to produce Fair Society, Healthy Lives, documenting in detail the persistent, in some cases widening inequalities in health in our society. And those inequalities have been further exposed by COVID. People who live in deprived communities and areas have been more adversely affected. People in many of minority ethnic groups, likewise, people with underlying health conditions, and of course, older people too. Marmot's update of this 2010 report was published in January this year by the Health Foundation, and it sets out in much detail, chapter and verse, if you will, what we've learned from COVID and how it's shone an even harsher light on these inequalities in health, which have persisted despite the fact that we have a universal, comprehensive, free at the point of use health service committed to principles of fairness and equity. Moving on to my next slide, of course, one of the factors at work here is that hospitals, the hospitals that are part of the Royal Free Group and others besides, can be very effective when it comes to saving lives and indeed prolonging lives. But if health and well-being, improving health outcomes is our goal, we have to look at all of these other factors besides, what are often called these wider determinants of health and well-being, because these actually are more important than the organized health or medical care system when it comes to shaping the outcomes of health in our population than the services themselves. This was pointed out by Douglas Black back in 1980 in the first major report on inequalities in health. And if I think back to earlier in my own career, reading Thomas McEwan's book, the historical analysis that he published showing exactly the same. This is now over 50 years ago. So these are not new insights, but they're a really powerful and important reminder of some of the lessons that we've learned from COVID. And then if I could move on to my next slide. We've also realized the importance and indeed the neglect of social care during the pandemic. And this is political neglect by successive governments, and it's societal neglect. This is a report we published at King's Fund back in 2013, a commission chaired by Dame Kate Barker. We set up to look at the future of social care and arguing for a new settlement for both health and social care. Just one of many reports which have both diagnosed the challenges and come up with a prescription for what could be done to improve social care and its relationship with healthcare. What the Barker Commission argued is we needed this new settlement. We needed much more funding, particularly public funding, to sustain social care. We needed to align our entitlements to health and social care, moving away from means testing of social care to something much more like the equitable access we expect within the NHS. And of course, the need to raise taxes to fund a system of that kind. Hard choices, but necessary choices, which sadly have still not been confronted, despite promises by the current governments and previous governments to come up with proposals which would produce this long-term solution, which has been exposed by COVID. If I can move on to my next slide. This is where I want to join up some of the dots, because at one level, you can argue that COVID changed everything and changed everything utterly. But what I'm trying to argue here is, while that is undoubtedly true, a lot of things remained as they were before COVID. This is a very high level way of framing the challenges that we face, and indeed most countries like us face. We produced this back in 2015, 2016, so it predates COVID. And what it's trying to suggest is that if you look at the horizontal axis, think about care services on the left and health improvement on the right, and look at the vertical axis, what matters for individuals at the bottom and what matters for populations at the top. You can think about this in terms of four broad quadrants, and all four are really, really important. It's not a question of one taking precedence over the other. So for us as individuals, for our loved ones, when we need care and support, we would like to think we will always get quick access to high quality care in the general practice or in the hospital. But not just that, because alongside care, we want to use our services to make every contact count, to build in opportunities for prevention by making sure that screening is undertaken in a timely way, immunizations are provided, so that prevention and care go hand in hand. If we move up to the top two around populations, when it comes to care, we need to do much more around integrating care, not just providing great services which are fragmented and separate from each other. And the reason for that relates to the changing demographics and the changing burden of disease in our society. We have a growing population, but we have an aging population. And as far as the burden of disease is concerned, we have a population where, as we've succeeded in saving lives through the progress on heart disease and stroke and most forms of cancer, we have the new challenges around long-term medical conditions, chronic diseases, and the challenges of multi-morbidity and of frailty. And people will often be in contact with more than one healthcare team. They will require the expertise of different specialists and different services. They will not get the best possible care if those services work independently of each other. We need joined up care around people, around families, and around communities. That's why there has been much more emphasis on integrated care models. And beyond that, the last quadrant on population health. This is where making every contact count for populations, not just for individuals, becomes important. Improving health outcomes across whole populations, including the distribution of those health outcomes, focusing on those wider determinants of health and well-being. And recognizing too, the future challenges that arise through new risk factors, of which obesity is perhaps the most important. And that requires a wider approach of working in partnership between different services and different influences. If I move on to my next slide. Here are two reports we published at King's Fund in 2015, going beyond those high-level thoughts to say, well, okay, how are we going to do this? What are the changes that are needed to convert these ideas into something that will really make a difference in every community across the country? And we argued that we needed to focus on place-based systems of care as well as on population health systems. And the way I summarize this really is around the 3 Ps. So place is one, and that might be a borough, it might be a town or a city, it might be a neighborhood or a locality. We need to understand the role of each of those different places of different sizes and complexities. Population is the second P, thinking about everybody of different ages, of different income levels, of different education, and how we improve health across whole populations. And then the third P is partnerships, using all the assets that we have and bringing together local government, the NHS, voluntary community sector organisations and others, moving away, I suppose, we were arguing in 2015, from the direction of health policy over the last 20, 25 years, which is very much focused on organisations like foundation trusts or commissioners, or indeed local authorities, rather than how they can work together for the greater benefit of the populations they serve. And these ideas, of course, were picked up in 2016 when the Sustainability and Transformation Plans and then partnerships, the STPs, were promoted by NHS England. And they, of course, have now morphed into integrated care systems with the proposal through legislation that they become statutory bodies with legal powers from April 2022. So the means to deliver the ends of improved health and improved care. Can I move to my next slide, please? Because the Healthier Wigan Partnership, for me, is a great example of where this is already happening. I visited Wigan on a number of occasions to go and see for myself the work that has been underway there for the best part of a decade. And to cut a long story short, the political leaders in Wigan recognised, as austerity was beginning to bite, that with cuts in the spending of local authorities, they would not be able to cope with those cuts by salami slicing their budgets and making incremental changes here and there. They had to be bolder and more radical. So the leader, who at that time was Peter Smith, now Lord Peter Smith, with Donna Hall, the council's chief executive, with Kate Ardern, who's the director of public health, with many other colleagues, they set out on a different path. They recognized they needed to be bolder if they were going to both keep within smaller budgets and, critically, improve outcomes for their population. So the story of Wigan Council and the Healthier Wigan Partnership is how they did that, how they worked with their community, not persisted in doing things to the community, using all the assets available in the public services, in the private sector, in the soccer club, in the rugby league club, in voluntary organisations in particular. So at the same time as they had to cut back on council services, they set aside money to invest more in voluntary and community sector organisations. The small ships in the armada, if you will, often focused on very specific communities or needs in the population, and often able to provide more effective, more creative solutions than those available in the public sector. And what they also did as a council was to train all of their staff, hundreds of members of staff at all levels, to go out into the community, into the high street, into the community organisations, into people's workplaces. And the mantra was to have different open-minded conversations, to go and talk to people, to find out what matters to them, not assuming that the council had the answer, and then bringing that understanding back to shape how the money was spent in the borough. And you'll see in the report the King's Fund has published and other sources, very impressive improvements in the health of the population and in other indicators, showing despite the cuts in public services, they were able to deliver better outcomes. Just to give you one example, they commissioned an independent assessment across the whole of Greater Manchester, because Wigan is in the far northwestern part of the conurbation, to understand the happiness of people who live in the different boroughs and in the city of Manchester. And the latest results I saw suggested that Wigan was the happiest place to live in Greater Manchester of all of the different places. I don't think it's a coincidence that that's the case in relation to this very radical and bold approach that I've just summarized very, very briefly. So let me move on next to what does this all of this mean for the Royal Free? If I can have my next slide, please. This is the approach that we've adopted through the Population Health Committee that I have the privilege of chairing within the Foundation Trust. First thing we have to do was define, what do we mean by population health? And you can see the words there at the top. It's about improving physical and mental health outcomes, promoting well-being and reducing inequalities across an entire population, within and beyond the hospital walls. That's the critical phrase there. We've borrowed another King's Fund diagram, which you'll see as the sort of petals in the rows on the left-hand side under approach and actions. Again, there are four quadrants here, beginning with health, behaviour and lifestyles, moving through places and communities, on to strategy and clinical practice groups, and up to the wider determinants of health at the top left-hand side. And of course, right in the middle, embedding inequalities measures for routine monitoring, because we will only know if we're making progress if we measure the impact we're having within our 3 hospitals around different population groups. And we act on that data to try and reduce, hopefully eliminate, the inequalities and the disparities that exist. I'll speak briefly in a little bit more detail about some of the components here, because I want to try and keep my remarks to around about 30 minutes to allow more time at the end for questions and for discussions. So if I start with the places and communities we live in, we serve principally 3 boroughs, Barnet, Camden and Enfield, and they have similarities, but of course they have important differences. One of the key building blocks of our population health approach is the development of integrated care partnerships in each of those boroughs, recognising the importance that the boroughs have for people who live there, but also for our efforts to tackle inequalities and improve health. In the Barnet ICP, which if I can begin with that one, population is older than any borough across London. There are 3 priorities. One is to improve same-day access to urgent and emergency care, and also to, as part of this, improve discharge from hospital. Barnet is a very busy hospital. The beds are often full or nearly full. A&E is incredibly busy. So if we can discharge patients in a timely way to the appropriate place, the beds become available for those who really need acute hospital and specialist care. A second priority is working on frailty and the care of people with these long-term medical conditions which reflect the changing burden of disease. And the third priority is to transform care in care homes by providing stronger linkages to general practices, but also to provide access to specialist expertise from our hospital in Barnet into care homes where that's the right thing to do. All 3 of these priorities around the older population can only work if we get the GP practices working with the hospital teams, working with social care and working with the voluntary sector as well. And that is the role of the Barnet ICP, to be the place where that partnership working comes together with this focus around the needs of older people. In Camden, there are 5 focus areas for the Camden ICP. I'm not going to mention all of them, but I'll give you 2 examples. The first is the health of children and young people, because the population in Camden is much younger on average than in many parts of London. And secondly, mental health, learning disabilities, and autism. One of the interesting features in Camden has been the role of the Camden Health and Care Citizens Assembly, working with public sector leaders to bring in the perspective of people and communities in shaping what these priorities should be. I think actually there are some interesting similarities as well as differences between the Camden approach and the healthier Wigan Partnership I was describing just now. And then thirdly, the Enfield ICP. There are, we know, important inequalities in health outcomes between the east and the west of the borough. We know that obesity is a challenge for adults and particularly for children in Enfield. And here the ICP has identified 3 priorities. Again, mental health and well-being is one of those, as it is increasingly across the whole of England. Secondly, the uptake of screening and immunisations in the population. And thirdly, inequalities in minority ethnic communities. So I hope that gives a flavour of one of the most important strands in our work, but I could equally have talked about clinical practice groups where the GPs and the hospital teams are coming together under our population health approach in relation to frailty, in relation to children with breathing difficulties. And John Connolly, who's with us, can say more about that in our question time as we get into it. I do, as I move on from this slide in a moment, but not yet, sorry about that, jumping the gun. I do want to say a little bit about the Free as an anchor institution. This is an idea increasingly in good currency, not just for us, but for others beside. An anchor institution is usually a large public sector body which is embedded in its community and has a very important economic role in working with that community on some of the issues I've been talking about. On the slide, I mentioned our role as an employer. We have a significant contribution to make in creating access to high quality jobs for people who live locally through apprenticeships, through training, and through helping people into careers and work that have meaning for them. We have a role because of the amount of money we spend every year on procuring goods and services. If we could redirect a proportion of that into local businesses, we could contribute again around these wider determinants of health. And we have a role in relation to sustainability. We signed off as a board our green plan earlier this year. And that is an example of how, as an anchor institution, we can help to reduce pollution, to reduce carbon emissions, to create a more sustainable community through doing things differently, both within the hospital and in other ways besides. There's one other thing I wanted to mention from the population health approach, and that's what we're doing with our own staff, because we can support our staff, the 10,000 people who work across the trust, to live healthier lives. And we're doing that with support, valuable support, which I want to recognise from the charity, recognising also what an experienced staff themselves have had over the last year or so, and how it's even more important now that we redouble our efforts to create a healthy workforce and to create an environment that is conducive to that. So I will now talk about shared responsibility for health. This is my penultimate slide. This is something I feel really passionate about. It's the last piece of work I did when I was chief executive of the King's Fund. And just standing back, I would reflect and ask you to reflect in many of the discussions that I'm party to, both at the Free and elsewhere. We spend a lot of time thinking about how care is delivered to the people we serve and how that can be improved. And that's as it should be, correctly so. But we need to do much more on how each of us accesses care and how we can be supported to do so more effectively. In other words, the supply side is important, but the demand side needs much more attention. And that's why it's about shared responsibility, not personal responsibility, but the responsibility we all share to improve health and well-being. This is not new. For many years now, there's been recognition of the importance of this around chronic diseases and around multi-morbidity. Self-management support, giving people the tools, the confidence, the understanding to do as much as possible to improve their own health and well-being. The expert patient program is one example of that. Using health coaching and personalized care planning for people with long-term conditions. Recognizing the role of peer support programs. So in Wigan, when I first went to Wigan, I was taken to an urban farm, which is a place where there is care and support for people who are in recovery from alcohol and drug difficulties. And the people who work on the farm are people who themselves have recovered or are still recovering from those difficulties. It was a fabulous experience to see what wonderful work is going on, supported by trained clinicians and other health and social care professionals, but the core work being done by peers for peers. And of course, shared decision-making would be another example of shared responsibility. I remember about 20 years ago when I visited a well-known integrated care system in the United States. One of the medical leaders there said to me, you know, the most important members of the primary healthcare team, they're not the GPs, they're not the practice nurses, they are the patients, the people receiving care, because it's their decisions every day on their diet, exercise, lifestyle, whether they take their medications or not. It's those decisions that have a much bigger impact on their health and well-being than the decisions of the clinicians they may see a few minutes every year. And there's an eternal truth within all of that. This paper was written in December 2018. I think those arguments have been absolutely reinforced by the learning from COVID. Because alongside the hugely successful and impressive vaccination program, our own behavior in our communities, in our families, in our households has made a huge difference. The fact that we've followed the guidance, that we've engaged in social distancing, in hand washing, in face coverings, and much, much more, has been as important as anything else, as I've understood it, listening to the experts, than what's happened within the healthcare system. So shared responsibility absolutely must be at the heart of what happens in the future. Let's think about the demand side as well as the supply side. So my last slide, please. What I would want to emphasize, I don't want to overclaim for what we are doing. I'm passionate, and I hope you can see I'm enthusiastic. We've made a start, but as the quality improvement guru, W. Edwards Deming, famously once said, you need constancy of purpose when you pursue radical change of this kind. It's a job for 10, 20 years, not for 1 or 2. And I also would echo what Chris Whitty said in a lecture he gave last week to Gresham College. He talked about the improvements we've seen in relation to heart disease, stroke, and cancer, and said, look, these improvements haven't resulted from a big breakthrough. They've resulted from lots of small improvements which cumulatively explain the progress we've made. I'd say exactly the same about integrated care and population health. There is no big breakthrough. It's about persisting with the things that we know work well, and I've given you some examples of that. So let me close by thanking the charity for all of its support for our work with staff on health and well-being, work during the pandemic in providing meals, accommodation, and much more, work in support of the clinical practice groups, bringing together general practices and hospital teams. This is about using all of our assets for the benefit of the people we serve, not working independently. Thank you.
Thank you, Chris. That was an absolutely wonderful talk. Obviously, I'm sure you could have gone on far longer, but thank you very much indeed for what you were able to share with us. Also delighted to bring in John Connolly, who is the Royal Free Medical Director, who's going to take part in the Q&A now. I've got a good set of questions through already, but please, anyone in the audience, do feel free to ask questions, and I will moderate and curate those as we go. We'll take the first question, which is from Anna, perhaps for both of you. What's the Royal Free's approach to aligning hospital specialists with PCNs for priority specialties?
John, I'll hand over to you on this one while I take a breather and a drink of water.
So our approach builds on the work we've already been doing within the hospital over the last several years, which is based around clinical practice groups where we try to standardize and reduce variation in care. So we have worked with local primary care networks to try and share those pathways, to try and make sure that patients are getting the same standard of care across primary and secondary care, and that their care pathways are joined up. So as live examples, for example, to give you, at Barnet, we are focusing on the local priorities of the management of patients with delirium and dementia, especially those frail patients that Chris referred to earlier. And at the Royal Free site, we've started a heart failure clinic, which we've moved the management of heart failure out into the community, working with both our primary care colleagues, but also community providers, community nurses, to try and standardize the care across that place-based population. So I think that is going to be the major focus of our approach, which is to expand our current way of standardizing care, reducing clinical variation and improving outcomes across into working with primary care networks.
Thanks, John. The next question is from Sarah, who asks, with the work towards integrated health, will that also mean a move towards value-based healthcare models? It might be worth, for the purposes of our audience, explaining what a value-based healthcare model is. If I can ask one of you to do that.
Well, I think different people have different definitions, John, so we might ask Sarah what she means by it to avoid answering the wrong question.
That might take some time because these are all written questions, but
shall I have a go? Shall I have a go? Which extends up to my answer. So, my understanding, which is simplistic, I think, is that value-based healthcare is delivering the best possible outcomes for patients at the lowest cost. That means that we can invest in better management. And in fact, that really underlies the Royal Free approach to clinical practice groups, reducing clinical variation, making a sustainable future and delivering healthcare in that way. And actually, our chief executive has championed that approach for us. And our way of doing that is to bring multi-professional teams together to try and understand the care that we deliver now, to try and see where there is unnecessary or unwarranted variation. And by that, we mean things that simply add no value to patients. And we do that from the patient's perspective. Then we try to redesign care to make it the most efficient, most effective, to produce the best outcomes for patients. And I think it's worth pointing out that the charity has played an incredible part in that journey. We have almost 40 of these clinical practice group pathways. And the key intervention by the charity was to provide funding and training for us to engage patients in this journey. And I think one of the fundamental good things that we've done with that program is to have patient co-design, patients at the heart of everything we were deciding, and critically for many of those pathways, patients defining the outcomes rather than we as healthcare professionals. And if I was to look at one thing from that program that stands out above all others, it's that patient engagement and the patient-led co-design.
Can I add to
Thanks,
that, John? Now I know what value-based healthcare means. I think one key issue here is how do we avoid care being provided inappropriately? There's a lot of evidence, and I know the BMJ and others have been very active on this, that sometimes we provide too much medicine, that there is inappropriate over-treatment and over-diagnosis, as well as sometimes under-treatment. And one way of avoiding that is by seeing patients very much as partners, as they are in the clinical practice group work that John was describing, but also through shared decision-making. We know from the work of Jack Wenberg and Al Mully and others, if you have the opportunity as a clinical team to share with patients who are considering treatment options, might be an operation, it might be a test, it might be something else, not just the benefits, but also the risks, they will take different decisions where they don't have that information. And often they will be more conservative decisions. And that's a way of both improving value, to go back to the question, but also saving resources being wasted because you're not undertaking what might be a very complex and expensive procedure, because that's been the choice that people themselves have made. And I think that's a great example of what I was trying to argue around shared responsibility.
Fantastic. Got a lovely, slightly provocative question here from James. Do you think the NHS has the humility or the urgency to do what Wigan did with the Wigan deal? What would have to be true, particularly from the centre, for that to happen?
Well, I'm optimistic. I mean, just contemplate the alternative to being optimistic, but I am optimistic that the NHS is increasingly getting there. And let me say, one of the reasons is I have the privilege again of co-chairing the NHS Assembly, which colleagues don't know. It's a group of about 50 people drawn from all parts of the country, all parts of the NHS, local government, the voluntary sector and beyond. And we often talk about things like the Wigan deal and a different way of working with people and communities. And there's real enthusiasm in that group. And Simon Stevens set up the NHS Assembly, Claire Gerard and I co-chair it. And if that is anything to go by, I think there's a sleeping giant here. People only want to have the opportunity of going forward in this way and bringing people we're serving much more centre stage and having a bigger role alongside those of us in public services, because that's the best way forward. It has to be. So I think we need visionary public sector leaders like the ones in Wigan, and I'm confident we've got them, not everywhere, but I think we've got them in many places. And the critical thing about Wigan, finally, is that it came out of local government. And what I learned from going to Wigan is the NHS is now involved, but only after it could see the benefits through the leadership of the council. I think in the NHS, we need to be humble and recognise that there's a lot that local government can help us do better and lead us forward on, because we don't have all the answers, and indeed nor do the councils.
And Victor's actually asked a follow-on question from there around that innovation that's going on in the Northwest. Do you think a single NHS budget for medical and social care within a population improves social care? I think that's the model being trialled in Greater Manchester, but do we yet know the outcomes? And is that an area you think has got potential?
Well, Simon Stevens once famously said, if you merge two leaky buckets, you don't get a watertight solution. So I can see the logic in saying social care should benefit if we have a single budget. But by the way, they don't have a single budget in Greater Manchester. There's a misconception, I think, there about that. They're working incredibly closely in each of the boroughs and in the city of Manchester, and they're doing as much as they can to pool their budgets. But the NHS budget up there is as constrained as it is everywhere. It's not as if you've got spare cash sloshing around in hospitals that we can transfer over to social care. It'd be nice to think we had. We're really trying to make the best of two hugely pressurized and constrained services. So that's why I think we need to think more radically about a very different way of paying for social care, which will mean, in my view, we'll have to pay more in taxes to fund a sustainable system, because the social care market is creaking at the moment.
And a question from Sneha. What role does innovation, technology, AI and machine learning play in integrated care? Do we have the right infrastructure to use technology to integrate care?
John, do you want to have a go at that one?
So I think we are beginning that journey, is the truth. So if I talk about our experience at the Royal Free, we have used artificial intelligence and machine learning to detect early deterioration in patients at risk of acute kidney injury. We were probably one of the first in the world to introduce that. We're now using similar technology to identify patients who are at risk of deterioration. More recently, one of the things that really has changed during the COVID pandemic was the linking up of healthcare records through something called Health Information Exchange. That's radically changed the way that we work with our colleagues in primary care, so that we can see the same information. We can see the same information in hospitals, that all of which is critical to the management of patients. And hopefully the next step of that is to start to look at pooled information about populations at risk of specific diseases. So my particular interest is in kidney disease, and for many years we've had a fully integrated kidney care program, but we've never really been able to use data and analysis or machine learning to improve things. So I hope that is the next phase of what we do. And a critical component of that is the Royal Free's journey towards digital excellence and implementing an electronic patient record across all our hospitals.
I've got three questions here that I'm going to try and incorporate into one, all of which centre around health inequalities. First is from Mimi asking about how the Royal Free is incorporating health inequalities into the way we're prioritising clinically around the elective backlog. And then a further question as well around what we're doing in the Royal Free around Black and minority ethnic populations. So I wonder if we could have a sort of a general response around that inequalities question, which, Chris, I know you touched on in your talk already.
Yeah, so if I kick off on that, we've got some really good work that's been undertaken in the last few months by our analytical colleagues, trying to interrogate the routine data we collect about how different groups in the population access our services and whether we're treating them equitably or not. And this is new territory for the NHS. It's never been done before, and it's not a trivial set of issues to look at either, because you need to be sure when you see the results, they are statistically reliable and that you're not misinterpreting the data. So through the Population Health Committee, we've had 2 goes at this so far, because we need that baseline understanding before we go about trying to improve access for people from minority backgrounds or people from poorer backgrounds. We need to understand, well, where are we starting from? And I think we're now much clearer about that. You know, we're in the foothills. We can see the summit. It's a bit cloudy and covered in snow, but we know that's where we want to get to. And being able to understand that we know that we could do better, say around access to cancer care or access to elective surgery or access to diagnostic tests. The services we currently deliver are not as equitably provided as we would like them to be, and certainly not in line with NHS values, not because of any intentional inequity in service delivery, but it happens to be like that. And part of the reason is that more affluent, more educated groups in the population seem to be better able to access care more rapidly than other groups in the population. Maybe there are other factors we don't yet fully understand. So that's where we are, but absolutely with a commitment where we know there are measurable inequalities based on reliable statistical data. We will change how we deliver care, and that may mean reaching out to different communities who are less successful at the moment in reaching in to the services we offer.
And we've got a question now talking about staff. So you were talking, Chris, in your presentation about the importance of considering staff as a population within that broader population piece. And obviously, one of the things that the charity was able to do, thanks to the amazing support of people across all of the areas that we serve, we were able to put lots of supports in place through the really tough periods of the COVID epidemic. Now that we're moving into a different phase, hopefully a calmer phase, what do both of you think is needed in terms of supporting staff, retaining them in the NHS, giving them what they need so they can carry on, doing the fantastic job they do? And is there anything you've seen elsewhere, perhaps that you would love to see us introduce within the Royal Free and our other hospitals?
So, I think again, if I start on that, this is fundamental, isn't it? We can overcomplicate these issues, but healthcare is a people business. We deliver care through people to people. We know that happy patients result from having happy staff who feel valued and supported. And some of that's around the great support the charities provided around accommodation and food and respite and having quiet and safe spaces for staff during the midst of the pandemic, but some of it's about the culture within our organisation, and the culture in an organisation depends very much on the leaders in the organisation and whether the leaders themselves valuing staff, listening to staff, talking to them, seeking their views, and then acting on that. And there's very, very good evidence from many different sources and organisations that I've visited. So we're working on all of that. And again, John might want to give some examples of how we're working on it. But if over time we can strengthen our leadership, strengthen our ways of working, the listening into action program that I know is used in many trusts where staff go onto the shop floor and they just give staff the opportunity to express their views and to take feedback, hard as that might be in some circumstances. Because if we're not successful in doing this, and the pandemic's had a huge impact on staff in many different ways, then frankly, we'll be in great difficulty because we won't be able to retain, let alone recruit, the people who will carry on delivering the great care that we're able to at the moment.
Yes, if I could comment, I think the support for staff wellbeing was amazing during the pandemic. But like many things, it highlighted something that we probably need to do more of in any case, as Chris has said. So I think that staff need ongoing support development. A good example of things that have been really transformative are the rest spaces for staff, which are still being utilised, and new rest spaces, for example, in Barnet Hospital, accommodation, making sure staff can have rest during all of their work. I think the other areas which are really important to me are our quality improvement culture, whereby we really work with staff, train them in quality improvement methodology. We have programs, what matters to patients, what matters to staff, that I believe should be at the heart of improving patient experience and staff experience in the workplace. And then finally, I think we just need to invest more in training and development of all of our staff, not just some groups. We need to really give some benefits, some training in the things that will make them value their work and then be better at delivering care for patients.
Thank you both. We've got some outstanding questions, but unfortunately we've run out of time. So apologies to anyone who didn't manage to get their question asked. But please join me in saying a huge thank you to John Connolly and Professor Sir Chris Ham. We heard about the collaborative response of the North London healthcare system to the COVID pandemic. And obviously at the Royal Free Charity, all of us are enormously proud to have played the role that we were able to do through funding the training for clinical practice groups, which meant that when the pandemic struck, we could pivot in a swift way to provide essential skills and support patients and staff. If anybody watching would like to help us to help our hospitals even more, details of how to do that will be on screen shortly, or of course you can always Google the Royal Free Charity. There are lots of ways you can help, from giving a personal donation to cycling from London to Brighton if that's your thing, or giving your time as a volunteer. And if you would like to help, our contact details will be on screen at the close of the event, or they're available through our YouTube channel. If you enjoyed tonight's event, I do hope you'll enjoy us for our next one on the 21st of June, when we'll be joined by Karen Turner, the Senior Improvement Advisor at the Royal Free Hospital. Karen's one of the country's leading practitioners in engaging staff and patients on what matters to them in order to bring about real change, as John was just talking about then. So we very much look forward to finding out more about why that's so important and how it works at the Royal Free. My thanks again to Professor Sir Chris Ham and to Dr. John Connolly, and thank you everybody for watching. Good night.